My name is Dr. Benjamin Domb, and I am an orthopedic surgeon, honored today to be presenting at the American College of Obstetrics and Gynecology annual meeting here in Minneapolis. Perhaps one of the first times that an orthopedic surgeon has had this honor of presenting to the obstetric community. And I would like today to share with you 3 pearls to avoid liability from postpartum hip pain. 3 pearls that every obstetrician should know. And this was part of a presentation on postpartum hip pain here at ACOG, the prevention, the workup, and the management. My disclosures are listed with the AAOS, the Academy of Orthopedic Surgeons. This came to my attention first when a patient presented with hip pain, and I asked what happened, and she said, "My mother-in-law tore my labrum." I said, "What do you mean?" She says, "The mother-in-law actually pulled on her leg during delivery, and much more than the pain from actual delivery, she remembered the pain in her hip and continued to have that pain afterward. Fortunately, we were able to diagnose it and treat it with an arthroscopic surgery to cure her, and subsequently saw dozens more such patients with peri-partum hip pain or postpartum hip pain that had resulted from pregnancy or delivery. And in order to bring attention to it in the obstetric community, published perhaps one of the first articles ever published in the Journal of Obstetrics and Gynecology on acetabular labral tears and postpartum hip pain. So 3 things for the obstetrician to know. Number 1, what are the hip injuries? They are most commonly labral tears. The labrum is the ring around the edge of the socket. It's a cartilaginous structure that seals the ball in the socket. And when it's torn, it can cause pain or mechanical symptoms, including popping or locking. And pubic symphysis dysfunction. Everyone in obstetrics is familiar with the pubic symphysis. It gets wider during pregnancy in preparation for delivery because the relaxin in the bloodstream leads to loose ligaments, and it's expanding so that it can expand the birth canal. But if it stays expanded, it can cause instability and pain that can last long after delivery and sometimes forever. It's only diagnosed in 1 in 300 women, and it probably is as common as 25% of women who have persistent pubic symphysis pain. So something we can really spot and diagnose and help a lot of women. The second thing to know, when to refer to the orthopedic hip specialist. So if you have a patient who has at least 6 weeks of postpartum hip pain and it's not getting better with conservative treatments like physical therapy or pelvic floor therapy or even acupuncture and activity modifications, then it's time. It's time for an orthopedic specialist referral. And if there's one test to remember, it's the Fader test. When you examine the patient, try this: flexion, adduction, and internal rotation, Fader. If flexion, adduction, and internal rotation replicates the hip pain, it's probably coming from the hip. The third and final thing for the obstetrician to know to prevent liability: how to prevent these injuries. So the strategies for avoiding hip injuries during delivery start with avoiding flexion combined with internal rotation. It's okay if they externally rotate, but we do not want their knee going in and their foot going out. That's internal rotation. So we don't want that mother-in-law pulling on the foot or on the ankle. It's okay if the assistants, the nurses, or family members help the woman by pulling on their thigh, but they shouldn't touch the leg anywhere below the knee. Discuss that with the family and the caregivers, and you'll help prevent a lot of this. The delivery is safest when the woman herself is holding her own legs and no one's helping her, because she's unlikely to injure her own legs. So that wraps up 3 strategies for the obstetrician to avoid liability due to postpartum hip injuries, presented here at the American College of Obstetrics and Gynecology. I hope this was helpful, and greetings to the obstetric community from the American Hip Institute.